Good afternoon and welcome everyone to our online information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. I'm joined today by Dr. Eric Bowe, Director of Infection Control Services at CancerCare Manitoba, who will be sharing his expertise about COVID-19 and vaccinations. We are very pleased to offer this session with the generous funding support of the CancerCare Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusivity and reconciliation and encourage others to do the same. Before we continue, there are a few basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question for Dr. Bowe at any time during the presentation, just click on the Q&A icon on your screen and type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. My coworker Ellie is also here off screen and she will be helping us manage your questions as they come in. If you have a technical concern, you can also ask Ellie in the Q&A and she will answer your question privately and try to assist you. It's now my privilege and my pleasure to introduce our guest today. Dr. Bowe is Professor of Medicine and Medical Microbiology at the University of Manitoba. He was recruited to CancerCare and the University of Manitoba in 1982 as an infectious disease physician and hematologist oncologist, with special clinical and research interests in the infectious diseases of cancer patients and in the hematopoietic stem cell transplantation. He provides clinical consultation services for oncology and transplant infectious diseases at CancerCare Manitoba and to the Health Science Center. Dr. Bowe's expertise also includes febrile neutropenia and infections related to stem cell transplants. Welcome, Dr. Bowe.
Thank you, Kathleen. It's a pleasure to be with you this afternoon, and we'll get started in this topic. I think the first things to discuss are the objectives, the areas I'd like to try and cover. One, I'd like to give you a summary of the history of this pandemic that we have been experiencing and is not yet over. I'd like to have a word or two on the impact of COVID-19 pandemic on cancer care. A little off topic, but I think it's still very important for us to be mindful of how these events affect the care that we can provide. And I'm going to spend a little bit of time talking about some of the vaccine principles and some of the immune responses that are expected associated with SARS-CoV-2 and the vaccines. Some comments about vaccine effectiveness, and with special attention at the end of this discussion to the expectations for the bivalent vaccines, which are currently now available for us in Manitoba. Well, with that in mind, this first slide depicts graphically the pandemic timeline. And what this represents in the arrow in the foreground and all the little numbers within it are the months of the years of these past 3 years that this pandemic has been present and affecting us. And this goes from November of 2019 until this month of December of 2022, excuse me. And within that, there have been a number of different variations on this same virus. At the left-hand side of the slide, you can see at the very left-hand side is the Wuhan wild type. Again, this is the virus that was initially identified in Wuhan, China. And this serves as the ancestral strain, if you like, for all of the subsequent strains and variants of concern and subvariants of concern that have been identified. After the Wuhan strain, one important mutation in the virus occurred. It's been labeled D614G. Now, what that simply means is in the three-dimensional chain of the amino acids of the spike protein, the actual place where in the virus that attaches to the human cell receptor. I'll talk a little more about that a little bit later. that there was a substitution of a single amino acid, which conferred on the virus the characteristic of increased transmissibility. And that has been the pattern for all of the subsequent strains, variants of concern, and subvariants of concern since that first ancestral strain became more widespread, particularly in China. Subsequent to the D614G was another one, the beta strain, initially seen in South Africa. Then in the UK, there was the alpha strain, but others in the Philippines, mu, Brazil had gamma, Peru had lambda. And again, these had relatively limited spread compared to, say, 614G and the alpha. Then following the alpha, as you can see, this all blends in one to the other during 2021, came the Delta strain, initially identified in India, and a related strain, Kappa, but it's Delta that has taken the predominance worldwide. And then subsequently at the end of December 2021, early January 2022, we started hearing about this new chap on the block, Omicron. And Omicron is not just one virus, but several different strains. And all of these strains together produced clinically, from an epidemiological perspective, a number of waves. And I'll argue that we're currently in this 7th wave of the whole pandemic. And over on the right-hand side of the slide, under the Omicron peaks, you'll see the first Omicron wave 5 was characterized by this variant called BA1. And this was really predominant in May and June of 2022, this year. But shortly thereafter, in the summer and early fall months, came the wave 6, and that was BA2. And there are other minor variants along with that. And then as we moved into October, November 2022, we started hearing about some of these other ones, particularly BA4, BA5. And subsequent to BA5, subvariants have developed, BQ1 and BQ1.1. Now, I appreciate no one really remembers these things except infectious disease physicians and microbiologists. But what they have is characteristics that are relevant to everybody in the community. The Delta strain was characterized in comparison to Alpha and the earlier variants by increased transmissibility within our communities and increased virulence. In other words, it spread faster, it was more easily transmitted, and it made people sicker. What's characterizing the latter subvariants of Omicron is increased transmissibility, but apparent less severity or virulence. And I'll come back to that in a moment. Part of this timeline is the introduction of vaccines back in March of 2020. Now, the vaccines were all based upon the Wuhan wild type ancestral strain. As we see these new variants of concern develop, there have been mutations which have conferred, if you like, relative immune resistance to some of the antibodies which are produced as a function of that ancestral type strain of SARS-CoV-2. The more widespread availability of the vaccines started to become more apparent in late 2020. And it's after that all of these other strains apparently have developed. I'll come back to that point a bit later. Let's see how we can do. Now, a recent study, when I see recent, I mean it was this week, out of South Africa, gives us some thoughts about the virulence of these different variants of concern. Now, if I could just direct your attention to the left-hand side of the slide and the green bars. these are some data, population data in South Africa, which is looking at markers or surrogates of virulence of the various strains, as illustrated by severe disease enough to get people into hospital. So these represent hospitalizations per 100,000 people in that area of the world. And at the bottom of the graph here are the various variants of concern. D164G, the beta, develop, and two groups of Omicron subvariants, BA1 and BA2, BA1 and BA3 to BA3, and then BA4 and BA5. In Manitoba, currently, the predominant circulating strain is BA.5. So what I'm showing you here is that the severity, as measured or estimated by the number of hospitalizations per 100,000, was highest for the Delta strain. Next was the Beta strain, the one that was really predominantly in the UK, and then less so with the Omicron strains, as you can see as we move to the right-hand side of that particular part of the graph. Now, some of these data are confounded by the more widespread availability of vaccines and the more widespread availability of the treatments that we have come to rely on for Omicron and SARS-CoV-2 disease. But nevertheless, when controlling for some of those factors, it does seem that Omicron is less virulent, albeit much more transmissible. Many more people have gotten Omicron than had gotten Delta.
Dr. Bo, I'm just sorry if I could interrupt you. Could you just explain what virulence actually means or what it's referring to?
Certainly. The virulence is a term used to describe sort of globally the severity of the disease produced by the infection.
Okay, thank you.
If I just give you a couple of examples, if I get a cold and I've got a runny nose, a bit of a sore throat, but little else, that would be a pretty mild upper respiratory infection. But if that progressed to the point where I became symptomatic with a cough, evidence of being breathless, and developing pneumonia, such that I required oxygen to remain awake, if you like, that would be much more severe, and that would require me to be hospitalized for the treatment and management of that infection. So within the spectrum of disease that we see with SARS-CoV-2, that would be the estimate of virulence, that is, the severity of the symptoms that are produced in people who get the infection, and things like hospitalization, need for oxygen, need for intensive care unit, or even death. On the right-hand side of the slide is more data from the same study, looking again at hospitalizations per 100,000 people, but broken down not only by the variant of concern, but by the age of patients in that setting. And what I'm trying to show you here very briefly is this classical U-shaped phenomenon. That is, the people who are most affected by the severity of the disease are the very young and very old. This observation is not new. We've had this same phenomenon associated with influenza virus infections and respiratory syncytial virus infections. Yet this is following the same pattern. So as you can see, the older you get, if you get the infection, the sicker you are. In other words, in this case, need hospitalization. But if it's a different variant of concern, like Delta seems to be, and that's in the red solid line, that's if you got Delta, that's a greater risk of requiring hospitalization. It's a more virulent kind of infection, more severe symptoms. And that may translate into fatalities. This information from the same data set reflects the mortality among the hospitalized patients according to the variant of concern. And once again, Beta and Delta variants seem to be associated with a greater risk of death. In this case, the case fatality ratio, which reflects the number of cases and those cases who actually died of the infection. And this suggesting that, again, with beta and delta, that of those people who got the infection, who got sick enough to go into hospital, more than 1 in 4 of them passed away as a function of this infection, but much less so on the right-hand side of the graph with Omicron variants, and again, controlled for other things like age and use of vaccinations.
Mhm.
Now, vaccinations become really important in this consideration. And again, this is the last part of this data set. This is looking at the odds of dying if you are hospitalized according to whether you've been vaccinated or not. And not only that, whether you've had partial vaccine, in other words, maybe 1 dose out of the 2, or whether you've been fully vaccinated, at least 2 doses of the vaccine, and whether you've had a booster, or whether or not you've actually had COVID-19 proven. So in this bit of information, this is comparing the odds of dying as a function of the infection according to vaccine status compared to if you did not have any vaccine. So a partial vaccinee had an odds reduction because of having a little bit of vaccine of about 10% compared to having no vaccine. If the person was fully vaccinated, a 40% reduction. If they had full vaccine and a booster, 60% reduction, and prior lab-confirmed SARS-CoV-2 infection causing COVID-19 disease, another 60% reduction. This just illustrates the importance of having full vaccination and also the impact of having had, unfortunately, an experience with COVID-19 infection that also augments your immune responsiveness. And that's rather important. So those patients who have had COVID-19 and who get vaccinated have a reduction in risk of death that's quite significant. So let me just turn to the paradigm, and I've made reference in my comments to this previously. So those individuals who are exposed to the virus, SARS-CoV-2, may end up with an infection or not. In other words, not everybody who's exposed will get infected, although with the more transmissible strains, the probabilities are a lot higher. Of those people who get infection, there are a proportion who will remain asymptomatic. Now, they're harder to detect, aren't they? Because we look for tests, and if they're not symptomatic, we may not do a test. So the number or proportion of all those that get infection that are truly asymptomatic, we really don't know what that proportion is. But those who are symptomatic of the infection, we can break that down into mild, moderate, or severe. Now, the differences is in how patients feel and how they're impacted by the infection. For example, as I spoke about before, if I had just a bit of a scratchy throat and a runny nose, maybe a bit of a cough, that might be considered mild. However, if I have fever, I have chills, my muscles ache, my bones hurt, and I'm feeling quite a bit less well, and I have to take to bed because I'm fatigued, that would be considered moderate. However, if I get sick enough to require medical care, hospitalization, that's considered severe. And as you can see, the likelihood of dying is more so with severe disease than with any of the other sort of categories. For those patients who recover with an immune response that can add to the vaccine they might subsequently get or had gotten to keep them free of severe infections from then on. So at the bottom of the slide is just to give you a sense of some of the things that happen in response to these infections. In the green on the left-hand side is the development of protective immunity characterized by neutralizing antibodies to the spike protein, which is the piece of the virus that sticks on to the human cell in the respiratory tract. And then there are other cells in the body, T cells, that play a huge role in taking up the gauntlet, so to speak, and helping to protect us against the more severe consequences of the infection. On the right-hand side of the slide are the more difficult to manage consequences of the infection, often related to the body's really exuberant response against the virus itself, and may lead to what's called immune dysregulation. The inflammatory response leading to cytokine release, various anti-infection protein factors that the body produces, but then in of themselves can produce lung injury and respiratory distress and clotting abnormalities that all conspire to make the disease that we see at the bedside more severe and more likely that the patient is going to require medical care in hospital. Immune-suppressed cancer patients have been identified as having some unique characteristics when they do get the infections. They are not more likely to get infection due to SARS-CoV-2, but they are more likely to have a severe consequences of the COVID-19 disease. So that's important for us to know. And just to illustrate that, here are some data that were published last year, looking at cancer patients in the red bars versus non-cancer patients in the yellow bars. And what I'm trying to show you are 3 outcomes of infection that are severe. Hospitalization on the left-hand side of the graph, in the middle, need for ICU admission, and in the right-hand side of the graph, 30-day all-cause mortality. And what I'm trying to show you in this is that in each case, cancer patients are more highly represented. They're more likely, if they get SARS-CoV-2 infection, to have severe disease requiring hospitalization, more likely than not to require ICU admission because of the severity of their disease, and more likely to have a fatal outcome. Now, that's important. So we have to spend some time thinking about how do we mitigate this. And these were all data taken among patients who had not been vaccinated. Furthermore, cancer patients in general have a more prolonged SARS-CoV-2 infection duration, and that translates into a more prolonged period of time with virus shedding, meaning that a cancer patient and an immune suppressed patient with the infection can shed the virus into the environment, if you like, much more for a much longer duration and potentially infect more people in that same environment. So there's a transmissibility and public health issue attached to this. Also, in this population, what has been documented is that there is a greater risk of viral evolution, genetic evolution, with increasing numbers of mutations leading to escape mutant variants. And what that means is variants of concern or subvariants of concern that take on characteristics like transmissibility or virulence that can infect other people and other cancer patients. Also, the titers of neutralizing antibody to these variants tends to be lower. And what the word titer means is amount or a concentration of antibody against a particular virus or component of the virus. So in other words, a normal person, I'll just give you an example, might make to a vaccine like influenza vaccine 100 units of antibody activity, whereas a cancer patient who's on chemotherapy might make only 10 or 25 units of antivirus activity. And so it doesn't mean that the patient is incapable of producing an immune response that's helpful, but the magnitude of that immune response is reduced. And we have to pay attention to that because that adds to risk.
Dr. Bo, if I could
Yeah.
just clarify, just before we go on too much further, but in
Mhm.
the previous information you were showing, you said that the rates of hospitalization and ICU admissions for cancer patients were higher. And did you say that that was based on cancer patients that hadn't had vaccines, though, that research? That,
In that one slide, that data, that was
yeah.
correct.
Okay, so would that be these points that you're talking about now, would that still exist even if cancer patients had vaccines? They would still be at risk for more severe COVID diseases?
They were still at risk on average, yes, but in comparison to those same individuals who had not been vaccinated, the risk of severe disease is reduced.
Okay, thank you.
So when I'm saying, just to clarify that point a bit further, if I'm saying there's an increased risk of severe disease, that's compared to immune competent people without cancer.
Okay,
Good
thank you.
question. Thank you. And I just, what follows here is that these characteristics lead to enhanced transmission within the household contacts of our cancer patient population, more likely to spread it to others because of the prolonged duration of shedding of the virus. And also, it follows that there is an increased risk of breakthrough infections to subsequent strains, despite being having a primary vaccination and booster vaccination as well. But as we were just saying, the severity of the disease in those circumstances would be reduced. And that's an important benefit. So let me just focus on this severity concept for a moment. This is just one paradigm that has been published by the Infectious Disease Society of America and the Centers for Disease Control in Atlanta, Georgia, looking at risk of severe disease according to various characteristics that given individuals might have, both cancer patients and non-cancer patients. Let me just direct your attention to the top row. And the category here is one of age. And what we're trying to show here is that the risk of severe disease is lowest in the youngest individuals and highest in the oldest individuals, if you like. So that's where the red comes in, trying to give you a visual appreciation of that. But age is not the only story here. There are other medical conditions that we acquire as we go through our lives. And this can be examples like diabetes mellitus, chronic kidney disease, obesity, lung disease, any number of, if you like, medical conditions. If you have none, the risk is lower than if you have some. And if they accumulate, that is one in the middle, two, a little over to the right, and if three or more conditions, the risk is higher of having severe disease. Vaccination status plays a role, as we were just mentioning. That is, those individuals fully vaccinated, the risk is lower. For those who are unvaccinated, the risk is higher. And it's midway among those who have full vaccination without booster or only partial vaccination on a cumulative risk. And then those people who are immune suppressed, either by underlying disease like a cancer or the treatment for that disease. And again, if there's no immune suppression, that has the lowest risk. And those individuals have the highest immune suppression, like those who have undergone stem cell transplantation or solid organ transplantation, or have a hematologic malignancy as opposed to a solid tissue malignancy, are at a differential risk. What I'm trying to get at here with this diagram is that it's no one thing that contributes to the risk. It's a composite of several characteristics, only 4 being illustrated here in this example. But there are others. But these are the kind of characteristics that we need to pay attention to when we're trying to assess the risk of people having severe disease and requiring medical interventions or access to our healthcare system.
Dr. Bo, there's a question from a patient that might be relevant to that slide. Just he was saying that he has finished radiation for prostate cancer, not undergoing chemotherapy. Would he be considered not immune compromised
It would be
anymore?
considered, just without knowing more specifics, but in general would be considered not immune compromised.
Okay, thank you.
It's a good question. So this next component of this discussion is to focus on what is the impact of this pandemic on cancer patients. And for this, I've taken some information from a friend of CancerCare, Dr. Michael Richards, who's visited with us several times and has offered counsel on how we should best be managing patients. And these are some observations that he has come up with in looking at the same question in the United Kingdom. So just direct your attention to, to the left-hand side of the slide. There are a number of clinical observations that underlie this whole paradigm. One is, as I have mentioned, cancer patients are not at greater risk for SARS-CoV-2 infection compared to non-cancer patients, but they are at increased risk of more severe disease, requiring hospitalization, requiring ICU, requiring mechanical ventilation. And as I mentioned, the risk of death is still higher. So that plays a huge role in how we proceed, those observations. There have been delays documented in diagnosis based on, say, redeployment of skilled healthcare providers, suspension of screening programs like breast screening, cervical screening, colorectal screening, that play a huge role in the early detection of cancer development. There have been impacts on diagnostic services, decreased availability of endoscopic services because of the nature of the endoscopic procedures promoting the spread of the SARS-CoV-2 infection, and decreased numbers of surgeries to make diagnoses and to provide debulking therapies. They're just not being available in the context of this pandemic. Also, there have been some impact on treatment pathways, modifications of chemotherapy, for example, moving from parenteral or IV chemotherapy to oral treatments, or limiting treatments that have only marginal benefit. Changing the fractionations of radiation therapy, for example, or modification of neoadjuvant therapy before surgery in an attempt to reduce or the bulk of the tumor. All of these things have contributed to some impact for our cancer patient populations. And then there's the more public health changes in the priority for healthcare. That is, changes from specialist care to primary care, and changing the pattern or process for follow-up from on-site or personal visits to virtual visits. The changes that we've experienced here in Manitoba with emergency care, surgical care, critical care services being overwhelmed, and palliative care services also being overwhelmed. And then lastly, there's been an impact on clinical trials. We've always felt that patients who are on clinical trials have typically done better, if you like. And so there's a pressure to bring people into the clinical trial fold and make them aware of the importance of clinical trials. But these have been suspended during the course of the pandemic to a great extent in different parts of the world. And so a reduction in therapeutic options for patients has been the consequence, and the delayed development of new and effective treatments. All of these things have conspired to impact on cancer care in general. Here at CancerCare Manitoba, investigators have looked at this question, trying to understand how we behave in our provision of care. Has that affected our patient population? So what we have taken is the principle that we need to reduce the exposure of patients and staff to SARS-CoV-2 in the cancer center itself. We want to be part of the problem. And so the goal to do that is to enhance isolation or distancing by reduction in traffic within the cancer center. So that increased the number of virtual visits, replacing on-site or personal visits, the exclusion of family and friends who may be normally accompanying patients to their appointments. Many of the staff members have been encouraged to work from home for many of the things that they do, except when they have clinics. And then there's been this impact on diagnostics services like diagnostic imaging and laboratory testing. That is a reduction in the non-urgent procedures. Despite all of this, however, what we have found is that although certain services have been impacted, like urgent cancer care, the overall service delivery has not changed from the pre-pandemic era. Even though there have been more inconveniences, there have been changes, to be sure. Diagnostic services are often outside of our control at CancerCare, but for the services that we have control over, we've been able to find that, yes, with some exceptions, we've been able to maintain a service delivery, even though it has not been the baseline service delivery. So I thought you'd be interested in that.
Yeah, for sure. Dr. Bowe, this is a good time to introduce our first poll and get some feedback from our audience in terms of what their experience has been like throughout the pandemic with how they feel their medical care has been. So I'm just going to launch a poll to your screen. So you should be seeing a poll on your screen, and this poll is completely voluntary and anonymous. But basically, we're just curious as to how you think the pandemic has impacted your medical care. So you can choose as many of these responses as are applicable to you. And then once you've selected your answers, you can just close the poll, submit and close the poll, and then I'll share the results once we have more people participate. So we're just waiting for people to respond to the questions. And I think, too, Dr. Bowe, some of this is very, I guess, qualitative too. I mean, the feeling of an experience, right, is something is hard to measure sometimes. How people feel about the experience of coming alone to an appointment as opposed to being able to bring somebody, and how much of an impact that has on the feeling of how the whole pandemic has impacted their care. So.
That's correct. Having family members and people interested in your well-being along with you in attending these really important appointments is just ever so important and very powerful in helping patients cope with what they're having to deal with. And so making these restrictions has an impact on the, if you like, mental and psychological well-being of our patient population.
Mm-hmm. I'm just going to end the poll. If you actually aren't seeing a poll on your screen, you can also submit your comments in the Q&A, and then Ellie will share them, and I can comment on them as well. So we just have a couple more people that have voted. Yeah, so please feel free to use the Q&A for your feedback as well. Actually, I won't close it quite yet. There's just a few more people coming in, so our numbers are just jumping a little bit more. Okay, I'm going to end that there. We have 66% of our audience that responded, and I'm just going to share the results to your screen right now. So, Dr. Bowe, are you seeing those results there?
I am, thank you.
And would you like to comment on that?
I would. Some of the responses are expected and kind of reinforce, my sort of general thoughts about this. For example, the one, I could not meet with my doctors in person. Well, of course, that's given the pressure to keep as few people in the institution as possible is a consequence. But it's that quality of that interaction. And I don't know about you, but I find that that meeting with my doctor is very important, person to person, as opposed to virtual or by telephone.
Yeah, definitely.
I really appreciate that comment. And again, about just over half of the individuals found that they could not attend the appointments with their supportive people. And then the other one was some tests were postponed or delayed, and that I agree with. Tests like diagnostic imaging or endoscopic procedures, and certainly because of the closure of surgical suites in the province, many surgeries were delayed, weren't they? So this had a major impact on the sort of the flow of our practices, if you like, throughout the province and throughout all of the different specialties and subspecialties of medicine.
Thank you, Dr. Bowe. I'm just going to stop sharing now and let you continue with the slides.
For some reason it's not proceeding, so let me just see if I can make it go. All right. Now I'm just going to turn my attention to immunization, and thought I would talk about the principles of immunization, particularly as it applies to cancer patients. First part is, why do we immunize? Well, for children, we immunize to prevent illness, but in adults, we immunize to prevent severe illness and death. Now, that's a key difference. Our objective is different for adults than it is for children. Who's responsible for immunization? Well, I believe it's a shared response between specialist providers and the primary care providers, your family physician, and patients and family and household contacts are very important to form this concept I'd like to term the circle of protection. If you as a patient are not able to mount an immune response that's just like a normal individual, then other members of your family still can mount those responses and help to protect you by keeping them free of the infection. So that's what's sort of the idea of herd immunity, and I'll come back to that in a moment. And what vaccines are available? Well, there are inactivated vaccines and live vaccines. And a variant on the inactivated vaccines, it's not quite correct to call them inactivated, but we have a number of vaccines which are considered recombinant vaccines. And that's what we are experiencing with the mRNA vaccines for SARS-CoV-2. The timing of the vaccination process is important. And ideally, it's important to vaccinate prior to any planned chemotherapy, radiation therapy, or immune suppressive therapy. For live vaccines, typically would recommend 4 or more weeks prior to beginning these treatment programs. For inactivated vaccines or recombinant vaccines, for 2 weeks or more prior to beginning these treatments. Now, the reason for the 2 weeks is that that's the amount of time it takes for the body to produce a robust immune response. And I'll come back to that. For immunization during chemotherapy or radiation therapy or immune suppressive therapy, we have to assume that the effect of the vaccine is suboptimal. We make that assumption just in general because of the immunogenicity is reduced under those conditions. So inactivated vaccines, they must be considered incomplete. And in some cases, re-immunization becomes important later on. Live vaccines, for the most part, are contraindicated. The reason for that is among immune-suppressed patients who might be getting a live vaccine, the live vaccine can actually produce significant disease. The risk is low, to be sure, but it is possible. And so we make that distinction. A live vaccine is contraindicated. After treatment has been completed with chemotherapy or radiation therapy or immune suppressive therapy, We suggest that 3 months or more after the completion of treatments, for those patients with hematologic malignancies who have received anti-B cell antibody therapy, such as rituximab, 6 or more months, simply because of the profound immune suppressive effect that has on antibody producing potential for people. For those who have undergone hematopoietic stem cell transplant, inactivated vaccines can be given starting between 6 and 12 months post-transplant. But for live vaccines, 24 months post-stem cell transplant is our usual recommendation.
Just a question about medications, Dr. Bo, from one of our patients asked, they've been completed chemotherapy and radiation for almost a year, but they're taking tamoxifen and having side effects from that. Is that going to affect their immunity?
No, the tamoxifen or drugs like tamoxifen would not be considered highly immune suppressive. So would be all right. And the expectation would be that you would, under those conditions, get a good immune response that would be protective.
Thank you.
I mentioned the term herd immunity, and I've just used this diagram to illustrate. These individuals holding umbrellas in blue are protecting the person without the umbrella in red from the rain. And because that individual can get under the protective umbrella of these others around him or her, doesn't get wet. So I'll illustrate that a little bit further. On the left-hand side of the slide, and on the left-hand part of the slide, is this circumstance where people in blue are non-vaccinated, people in yellow are healthy, vaccinated individuals, and those in red are non-vaccinated, but become infected and are sick and potentially contagious. And what I'm trying to show you here in the left-hand side of the slide is that those blue non-vaccinated individuals are easily exposed to the non-vaccinated, sick, contagious individual. And that leads to, on the right-hand side of the left-hand part of the slide, an increased number of transmissions in the community. With the exception of those people in yellow who have been vaccinated, a large proportion of the population becomes affected and sick. That's the worst case scenario. On the right-hand side of our slide, right here in the middle, if most of the people get vaccinated, and that's again in the yellow, you can see many more yellow folks here, and only a few of the healthy unvaccinated remain, the contagious sick individual has less opportunity to spread that contagious infection to the population. And as a result of the vaccination, many more people are protected, particularly those ones in the blue. So that's just really what is meant by herd immunity. So if I have 10 people in my group and only one of us gets vaccinated and then an infection is introduced, it's good possibility 9 others will get infected and sick. But if 9 out of 10 are vaccinated, we'll protect the one who isn't, or the one who can't make an immune response to the vaccine. And that's the principle of herd immunity, and that circle of protection within a family or small group.
So this is a question, Dr. Bowen, and I think a lot of people have had this question. Somebody here has written they are 7 years old and they had 4 COVID shots and still don't understand how they became sick with COVID and tested positive.
It's, as we said a moment just earlier, that it's quite possible for that to occur, and it's quite common. The point I'd raise is that the outcome you're after, if the outcome you're seeking is to not get infected, that may be hard to achieve in the best of cases, and particularly even in immune competent individuals who are vaccinated. However, what is really important is that the vaccines are intended to try and reduce the severity of of disease that one gets. So the hope, ideally, is that a vaccine will protect you against getting infection, or, as we say for adults, to prevent severe disease and prevent death. For immune-compromised individuals, they typically look more like adults, no matter what age. In other words, the risk of getting severe disease is there, and that is reduced by the vaccine.
Mhm.
Now,
Thank
in
you.
Canada, this is a list of all the vaccines that are available, or the types of vaccines, and I'm not going to go through that. I just want to focus on the middle of the slide, the kind of vaccines that are available for COVID-19 disease, and particularly the mRNA, that's the messenger ribonucleic acid vaccines that have been recently distributed for management of this infection and this disease. And there are two major companies, Moderna and Pfizer-BioNTech, that produce these products. And their major product that they have produced is based upon the Wuhan ancestral strain that I mentioned earlier in this discussion. But more recently, they have produced bivalent vaccines. Initially, against the bivalent would contain the Wuhan ancestral strain of mRNA vaccine, plus the newer Omicron variant of concern. The first products that were produced were against BA1 and BA2, but more recently, products are also containing mRNA for BA4 and 5. And that's for both companies, Moderna, the Spikevax product, and the Pfizer-BioNTech, which is Comirnaty, which is the brand name. Now, I think that's important to know. These vaccines are not new, at least based on they're not new principles. mRNA vaccines have been around for a great many years, but this is the first time that it's been on such a large scale and having such a major public health benefit for humans. There are other vaccines that are available in Canada, the adenovirus vector vaccines, protein recombinant vaccines, and plant-based recombinant vaccines. But for the most part, it's the mRNA vaccines that have been shown to have the greatest benefit, and I'll show you that in just a moment. From a public health perspective, let me just talk a little bit about the goals for community vaccination. These are the kinds of things that I have made reference to. That is, the outcomes are either to protect people from getting infection, but if that's not possible, to try and prevent disease and to try and prevent death due to disease. Among those in the middle here, to prevent disease, to perhaps guide the magnitude of the disease towards the mild and moderate and away from severe or critical disease. Now, these are the kinds of outcomes that epidemiologists and researchers use to determine whether the vaccines are effective. When you hear about the effectiveness of a vaccine, you have to be critical about what outcome you're really talking about. Is the vaccine effective for preventing infection altogether, or is it effective against severe disease, leaving people with only mild to moderate infection, and rather like a bad cold? Is it intended to prevent people from having to be admitted to hospital or having to be admitted to the intensive care unit or preventing death? All of these are really important outcomes that we need to pay attention to. But for the average person who's not thinking about public health goals for the vaccine, only thinking about what's appropriate for them, most people think, well, I really want to prevent getting the infection. But in reality, the vaccines that we have do a much better job in preventing severe infection as opposed to infection per se. That's an important expectation.
There's a question, Dr. Bo, about the booster shots. A question is, will you have to continue to get booster shots every so often, or or will immunity, I guess, just your own immunity develop over time? Or
That's a very difficult question to answer. But we have an answer for influenza, don't we? We have to get our annual seasonal influenza vaccine because our immunity from year to year for the strains that are circulating in the community change. And that's the same with the class of coronaviruses within which SARS-CoV-2 sits. We've learned from this pandemic that we have to after so many months get a booster shot to help protect us. Now, it remains to be seen whether public health will come out with a more predictable recommendation of having shots every so often, every year, every 6 months or so. We don't yet know for that, but it is quite possible that that's going to be what's required to keep people free of SARS-CoV-2, particularly when this particular virus produces, on the average, significantly more severe clinical disease than other viruses, respiratory viruses in the community that produce sort of the common cold symptoms that we see. This diagram that I'm showing you here, I'm hoping will help everybody understand a little bit about what happens when you get infected. If you get infected out here where my pointer is illustrating, there's going to be a period of time that the virus starts to gain hold and replicate and start producing tissue damage that we recognize as the clinical symptoms of the infection: runny nose, sore throat, headache, maybe fever. And when those symptoms start to become manifest, we call that onset of symptoms. So what we're showing you here is the surrogates of that process, measured by the rapid antigen test here in the green. And what I'm showing you here is that after the symptom onset is when we start to detect the virus by the rapid viral antigen tests here. Also, in the blue represents the RT-PCR, the polymerase chain reaction test that we do in the community. It starts to become positive earlier. It's much more sensitive, but it's detecting the RNA of the virus as it's being replicated, and tends to peak coincident with the peak of the rapid antigen test as well, but also peaks with the culturable virus, the ability to actually take the virus from a specimen from the nose and culture it in our laboratories, because it's the culturability that has the greatest relationship to transmissibility. So if you see what happens here with the RT-PCR test, it tends to lag along and stays positive for a period of time before slowly coming down after 2 to 3 weeks. The antibody response is illustrated in these other two lines. The first one I wanted to show you is this one here in the orange, which is the IgM antibody. You may have heard of that. And it's the first class of an antibody that is produced in response to a viral or bacterial antigen or infection. And it tends to be the first one that we detect. And if I detect it, I could say that there's been a recent infection, although the history may give me that same information regardless. But after the IgM antibody goes up and starts to level off and start to come down, what also happens is the IgG antibody molecules start to be produced, and this is what gives the longer lasting protection. And it's these kinds of antibodies that make up the neutralizing antibodies you've heard me speak of. These neutralizing antibodies are important to bind to very specific spots in the virus that are responsible for its replication. And if they can neutralize the virus quickly enough, you can mitigate, if not abrogate, the clinical disease that you see. And it's these guys, these antibody molecules, that we focus on in trying to maintain sufficient amounts of this antibody to protect us going forward. And that's really an important point. And what happens over time with coronaviruses, the same class, is that over time, usually about 3 to 4 months, this starts to fall off. And the boosters are designed to push up that antibody response again to maintain protection. So this is just a diagrammatic picture of what happens. Now, let me just take you through this and orient you. Up here at the top of the slide, this represents the virus. I don't know if you could see my, oops, I don't know what that is, but you can see that top of that's the virus here. And in the virus membrane sits this red glom of protein material or amino acids making up the protein called the spike protein. And this is a trimeric protein, 3 components to it, of which there are 2 major domains, the receptor binding domain here, and it's this receptor binding domain, and most importantly, this part here, that actually attaches to a receptor on the respiratory surface of humans. This is called ACE2 receptor, or a angiotensin converting enzyme type 2. And it's this relationship, 3-dimensional relationship, this sort of lock and key relationship between the spike protein in the receptor binding domain and the ACE2 receptor that allows the virus to attach to the human cell in the respiratory tract. And then this part over here, this membrane fusion domain, that binding stimulates a reaction right here that allows this part to come right down to the membrane and fuse with the membrane, allowing the virus to dump its contents, particularly its mRNA contents, into the host human cell to undergo replication, reproduction, and producing many more little viruses that produce damage to the tissue and disease that we see. Binding antibodies over here could bind here or here or here, but may have relatively little effect on preventing this major binding over here. It's here that we want to see neutralizing antibodies, antibodies that stick to the surface of the red part of the diagram here, to the virus, are the ones that prevent the virus from interacting with the human host cell in the first place. And that is what prevents infection. So the ability to do that is key to our success of vaccines and the antiviral effect.
And Dr. Bo, is that the same the same response when you've been infected by COVID to develop those antibodies, like whether you've had
correct.
Okay.
Yeah, that's correct. I'll just go back to that for a moment.
Yeah.
It's a very good point. If this happens normally, what happens is that this binds to that, and then a number of new viruses are produced, and it's those new viruses that interact with the person's immune system to produce new antibodies naturally against the virus, and T cells against the virus.
And so if someone has been infected by COVID, this is a question from one of our patients, is there protection indefinitely, even if the virus goes through more changes and variants?
That's the key question. I'm going to say no to that, and let me explain that a little bit further. If one gets infected by this particular virus and develops antibodies against this particular variant virus and produces, more importantly, antibodies against this particular area of the virus, that person is protected against that virus for as long as those antibodies remain elevated. However, what happens is if this changes in some way, in other words, I don't know if you can see this little bump at the side here, but if that's missing, the antibodies may not be able to recognize this area of the virus and are less effective in preventing that interaction between this part of the spike protein and the human host receptor, and be less able to ward off the infection.
Thank you.
And the mutations play a huge role. the more mutations in this area, the greater the risk that the vaccination or the previous infection may be ineffective. And that's called immune escape. Now, this is some information from a number of clinical trials that have been published on different vaccines, SARS-CoV-2 vaccines that are available. And what I want to show you in this graph is, along this side of the graph is vaccine effectiveness from low here up to 100% effective. And along here in the bottom of the graph represents the neutralizing antibody levels. So low down here on the left-hand side and high up here on the right-hand side. And what I'm showing you here in this red line represents the relationship between vaccine effectiveness and the amount or concentration of neutralizing antibodies produced by each of these different kinds of vaccine products. And if I just direct your attention, if you can see, follow my cursor up here to the higher parts of the graph, and this is where the mRNA vaccines sit. This is the Pfizer vaccine here, and this one here represents the Moderna vaccine. Now, even though there's differences in the amount of neutralizing antibody, you can see that from the curve that their ability to protect against infection and severe disease is very high, in the 90+% range. That's why public health officials here in Manitoba and elsewhere in Canada have felt comfortable in saying, if you can't get one of these vaccines, get the other. They're equally as effective in doing what it is that we want them to do. And that's the important message. So this is rather an interesting piece of information that gives me confidence that the immunizations that we have here available in Manitoba actually do a good job. They may not protect you against infection, but they will keep you free of severe infection. These are some data published from the CDC in Atlanta, Georgia. And again, this is more diagrammatic to illustrate the point. This is the percentage of patients here with antibody response. In other words, either you detect antibody against the virus or you don't. And what it represents is this dashed line represents the antibody response, yes or no, in 95 to 100% of healthy control patients, and compared those to patients with cancer. And in this particular example, the dark blue represents patients who have hematological malignancies like lymphoma, compared to solid tissue malignancies like prostate cancer or even lung cancer or breast cancer. In other words, what I'm showing you here is that those patients with hematologic malignancy have a higher likelihood of not getting a response to vaccination than their colleagues who have solid tissue malignancies. Patients who have kidney failure and are on hemodialysis, there's a range, but not nearly as great a deficit as you can see here with cancer patients. Organ transplantation in the middle over here towards the right, you can see that a great many more patients who undergo both solid organ transplants and liquid organ or stem cell transplants are unable to make an antibody response to the vaccines. And then patients who are on immune suppressive therapies for other reasons, like prednisone, corticosteroids, or many of the drugs that we use for rheumatological disorders like rheumatoid arthritis, also play a huge role in making patients more likely not to respond to the vaccines. So we have to pay attention to this in these special patient populations. Mm-hmm. Just to illustrate this a little bit further, this is, again, some more recent data. This represents the geometric mean titer, or amount of the antibody or concentration of the antibody per milliliter of blood, and comparing hematologic malignancies versus those patients with solid tumors, and comparing baseline amounts of antibody versus after one dose in the yellow of vaccine, and in the green after 2 doses of vaccine. And I'm just showing you this to illustrate the importance of having full vaccination as opposed to partial vaccination. So certainly those individuals who have had 2 doses of vaccine, and in some cases now, because we've changed our standards and saying full dose means in these patients 3 doses of vaccine as opposed to 2 doses that we'd use in immune competent individuals. We see that for patients with hematologic malignancies like lymphomas, don't get as high a titer or amount of antibody as their solid tumor counterparts. They certainly get a much poorer response after only 1 dose of vaccine in both cases.
Dr. Bo, could you give us an example of what are some of the cancers that are hematological malignancies?
Certainly. This is predominantly lymphomas or patients with chronic lymphocytic leukemia, myeloma, acute leukemias, chronic leukemias, and myelodysplasias would all fit into this category here.
Thank you.
And then patients with breast cancers, lung cancers, colorectal cancers, and the like, as just examples, would fit into that right-hand category. Now, this is to illustrate vaccine effectiveness as measured by need for hospitalization. Okay, and what I'm showing you here, these are data from the US, from a number of different centers in the United States. And what it's doing is trying to compare the duration of the effectiveness of the vaccine. So in the light blue represents vaccine effectiveness in percentage between 2 and 12 weeks from the time of vaccination, and in the darker blue, 13 to 24 weeks following vaccination. So on the left-hand side of the slide, you can see there's really no difference. That in patients who are, if you like, immune competent and have no other major comorbidities, the ability to retain that effectiveness in terms of having to be hospitalized with the infection remains stable and preserved up to 6 months, if not more. For those older patients than 65 years, it tends to wane somewhat. For those individuals, I'll just show you this in the middle here. For those individuals who would be considered immunocompromised, it's not as good. And that's what we're really learning, is that the vaccine effectiveness is not as high in patients for whom there is an immune compromising circumstance. For those, in contrast, who have a number of comorbidities, diabetes, some heart disease, blood pressure problems, the effect is maintained. It's just a little bit lower than for patients who are otherwise well. That's what we've learned over these last 3 years. Now, another thing I want to just show you, just to make the same point over again, is how long this effectiveness lasts, depending upon what outcome we're interested in. Now, this may be a little hard to see, but this is a group of studies that have been published. This particular study, a composite study of all of these studies put together, was just published this past week. And in the top of the slide under A, I'm showing vaccine effectiveness against infection. Whereas in the middle here, it's vaccine effectiveness against symptomatic infection or COVID-19. And then in the bottom here is vaccine effectiveness against severe COVID-19. And what I'm trying to show you, if I just draw your attention, this blue dashed line represents the 50% mark. That, in other words, half the antibody levels have dropped away and are not detectable by a given time. And what I'm showing you in the red dashed line is the vaccine effectiveness. And as you can see that that the vaccine effectiveness starts to drop off and drop below the 50% amount by 3 to 4 months in terms of the outcome of infection. And it's similar in the middle of the graph with symptomatic infection, that is COVID-19. But you can see that severe infection, the effectiveness is prolonged well beyond the 3 to 4 months. So if you say, ask me the question, when should I get my vaccine booster? Well, if your interest is in protecting yourself against any symptoms, then somewhere between 3 and 4 months would be a reasonable consideration. But if your concern is protecting yourself against severe infection or having to be hospitalized, you can wait even longer, out to 6 months. And that's what this information is telling us. Now, these are data that have been derived from non-cancer patient populations to really illustrate the natural history of the waning of, if you like, waning of the vaccine-induced immunity, to allow us to know when to recommend re-vaccination.
Super current too, and thank you. I'm going to launch our second poll if I can right now, Dr. Bo. So I'm just going to send that to your screen. We're just curious about how you feel moving forward on your cancer journey about getting your vaccine. So the question is, how confident are you in taking vaccines as you move forward in your cancer journey? So if you could take a moment, and Dr. Bo, while people are answering that poll, I just have a couple of questions related to lymphedema. Does that impact risk of COVID when there's problems with the lymph glands?
Lymphedema, for specifically as a factor in severity of COVID-19, or in terms of the risk of getting COVID-19, it is typically not a factor.
Okay.
It is, however, a factor in secondary bacterial infections that may complicate getting COVID-19. Does that make sense? In other words, we're hearing more recently on the news about children who have developed influenza infection and getting strep infections on top of that. The strep infection, the influenza infection made it more likely that the patient would develop a secondary infection. Well, the lymphedema has the same effect. It makes one more at risk for developing skin streptococcal infections, as just one example, but is not related to COVID-19. Having said that, if one has lymphedema, say of an arm, and developed COVID-19 and it was severe, it may make you unwell enough that you may make it difficult for you to defend yourself against the strep bacterium that would produce a skin infection related to the lymphedema. That's a bit of a step down the path, but that's how that would relate.
Doctor,
I don't know if that makes sense.
Definitely, yeah, thank you. I'm going to end the poll now and just share the results with you.
Well, this suggests that at least 3/4+ of individuals are very confident in that the vaccines are helpful, and I'm also glad to see there are people here who still have questions about vaccines, and as we should be questioning these things each and every step of the way. And that's why we do these studies, to be sure that we know what they can and what they cannot do. So I would be very misleading to you if I said you should get the vaccine and protect yourself against getting SARS-CoV-2 infection. I might be, whilst it's possible for the vaccine to achieve that for you, I would be misleading you in general, wouldn't I? Because we now know that it may not protect you against a breakthrough infection, but it'll keep you out of hospital. It'll keep you free of severe side effects of the infection that require a lot of medical care. And that's what we really want to do. We want to keep people relatively well, if we can't stop the infection, we can make the consequences of the infection in our communities easier to take.
Great. Thank you, Dr. Bo. We have about 10 minutes left. I just, we have a few questions that some patients have wanted to ask that are more specific to their treatments. So just so that we have time for those before 4:30, that would be great.
Okay, well, maybe what I'll do is I'll try, oops, if I can, excuse me 1 second. It's not allowing me to advance. Oh, there we go. There we go. I just want to make a few comments, and then I'll abbreviate this a little bit. But I want to make a few comments about bivalent vaccines and what the expectation is for these products. Let me set this up. This is a very jumbled bit of data on the slide, but let me just take you through it because I think it's worth understanding. And I just want to focus on the left-hand side of the slide. What I want to show you is that when you get a booster, if you've had your 2 or 3 primary series of COVID-19 vaccines, and you get a booster, that booster will increase your neutralizing antibody levels by about 11-fold. That's a lot, isn't it? I mean, that's huge. But that's what the typical ancestral Wuhan vaccine produces. A neutralizing antibody increase of about 11-fold. So what's the value added of a bivalent vaccine? And I'll make a difference here between, now bear in mind that the bivalent vaccine contains 2 components. One is the ancestral strain, and second is the Omicron strain. And of that Omicron strain, it might be the BA1, or it might be the BA5, or BA4 and 5. So if you know that BA5 is circulating in the community, but you get the bivalent vaccine that is, particularly the Moderna vaccine, that is the ancestral strain plus the BA1 mRNA vaccine, if you get that, you'll, on top of that 11-fold increase in neutralizing antibody, you'll get an additional 50% higher levels. In other words, a 1.5-fold increase over the 11-fold increase in neutralizing antibody. If, however, you take the bivalent vaccine that contains the circulating strain BA5, you'll go up to 1.75-fold increase over the 11-fold increase, which means you don't get a whole lot of benefit. It's a modest benefit in terms of the amount of circulating neutralizing antibody against the virus. It's higher, to be sure, but it's not hugely higher. It's not 20-fold. It's only 1.75-fold higher than the 11-fold that you would get with the Wuhan ancestral strain. And one of the reasons for that is that, remembering that the mRNA in this vaccine, it codes for spike protein with all different components to it, all different sides to it. Yes, we focused on that little part of the spike protein that attaches to the ACE receptor, but don't forget there's antibodies produced against all different components of that spike protein molecule, and that helps you get better. It helps protect you against severe disease as well. And that's what I mean by it may not protect you against infection, but it may protect you against severe disease, and that's the benefit that you get. And you get a modest increase in benefit if you're taking a bivalent vaccine that is matched to whatever's circulating in the community currently. So right now, BA5 is the predominant circulating strain. So the bivalent vaccine with the BA5 represented in it would perhaps be theoretically the best to get. But if there wasn't any, and only BA1 was available, I'd say get that, because that will give you a a significant benefit over just the basic ancestral strain. I don't know if that makes sense, but it's
could I try summarizing and see if I've understood it? So the first vaccine is on the left, right? So 11, that's the booster with the booster. And then if you get the bivalent with the strain of, is it an Omicron strain? The
Yep,
BA?
they're both Omicron strains.
Both.
And
okay. But one you would get more of a response for the BA1, is it you said?
no, you would get an increase in the antibody to the Wuhan strain, and you'll get a higher increase to the variant.
To the variant, okay, with the booster, the bivalent booster.
Correct. But if it happens to be matched as opposed to unmatched, then you get a bit of a higher effect. So in this case, what I'm showing you on the right-hand side of the slide in the red is where the bivalent is matched. In other words, you have ancestral strain mRNA and BA5 RNA, gives you a 1.75-fold increase over just the ancestral RNA vaccine alone.
Okay, so I guess the bottom line, I was going to say the bottom line, I guess, is it still worth getting the booster?
Yep. Okay. Absolutely. Yep. Even if you didn't have the bivalence and all that was available would be the ancestral strain, you'll get an 11-fold increase in your neutralizing antibody, and that will provide protection. If you have the option of having any bivalent, that would be what I'd recommend. And Perfect. If you have the option of having the bivalent that's a match to the circulating strain in the community, that would be the optimal choice.
Even better.
It only gives you a modest value added compared to the mismatched.
Okay, perfect. I got that that time around. It took 3 times, but I think I got it that one. Do we have time for some questions, Dr. Bo, right now? Or yeah,
Absolutely.
okay, that's wonderful. These are some specific questions people have had. One was about someone with non-Hodgkin's lymphoma currently being treated with ibrutinib, right?
Ibrutinib.
They've had 4 COVID vaccines and treated with COVID. Should they get the bivalent vaccine?
I think it would be helpful. I don't want to say it won't be harmful. I want to be careful because again, many people experience side effects of the vaccine, which is a good thing. The kind of adverse effects that people experience, some pain at the site of the injection, a bit of fever perhaps, that's your body responding to the vaccine, making antibodies and cells against the vaccine components. So that's a good thing. The question is, will you get that? Will you get a benefit from the bivalent? And my suggestion would be if you've had 4 vaccines, that is at least perhaps 3 primary series, 3 doses in the primary series and 1 booster, another booster, in other words, a 5th dose would be advisable because you'll get a benefit from that. The benefit will be translated into increased amounts of antibody, even though in the setting of having non-Hodgkin's lymphoma and taking a drug like ibrutinib, that the magnitude of that increase will be lower than for healthy individuals.
Okay, and they also had been treated with COVID as well, just to clarify. Treated for COVID, sorry. Is the vaccine safe and effective if you take this patient takes osimertinib? I don't know if I'm pronouncing that right.
Listen, try that again.
Osimertinib, OSIMER.
Yes, yep, got it. Yes, and there's, again, with many of these tyrosine kinase inhibitor products, there's a lot of, if you like, unwanted immune suppression. They do a good job against the tumor that's being treated, but they also have an effect of reducing the immune effectiveness, if you like, for the person. And so the real risk is that there would be a reduction in the amount of immune response that you can generate being on drugs like that one and on the previous ibrutinib.
Okay, thank you. Does an immune-compromised individual who receives, I think this is IVLG on a regular basis, get antibodies that fight COVID-19?
Good question. It's possible. It depends what pool of individuals from which the IVIG comes from. If it comes from a population of people who have been widely affected by SARS-CoV-2 infections, yeah, it's quite possible. And in fact, part of the anti-SARS-CoV-2 armamentarium has been using convalescent plasma from people who have had the infection and have recovered, and using that convalescent plasma to treat very sick people because it contains antibodies that can affect the course of the very sick person's infection. The commercial products that we have available to us have significant amounts of anti-SARS-CoV-2 antibody in them, it's not clear.
Okay.
Again, because we don't measure it, for one thing. And second, if it is there, remember, this is banked product, and so it's less likely to have a significant titer or amount of this kind of antibody in it.
Thank you. This patient writes that they have CLL but no symptoms and are not in treatment. Are they immune compromised? Would it be considered mild or moderate?
Sorry, what was the underlying disease again?
It's CLL.
Oh, CLL, yes.
Yeah, no symptoms and not in treatment.
Yeah, I think with that, I would have to say that because of chronic lymphocytic leukemia is a B cell disease and affects normal B cell function in producing antibody producing cells. Such an individual, even though they're not on treatment, would have a mild to moderate impairment of immune responsiveness. Doesn't mean they have no responsiveness, just means that that for any given vaccine, for example, the amount of neutralizing antibody that they would produce would be less than in a healthy individual.
Okay, thank you. I've got 4 more questions, so I'll try to speed through them. This one again has a word I'm not sure of, but non-small adenocarcinoma, EGFR. Not sure exactly what that, does that make sense to you?
So I think that again.
Yeah, Ellie? Yeah, would non-small adenocarcinoma EGFR be considered?
Okay, that makes sense. Now that's an immune therapy.
Okay.
And it's again non-small cell carcinoma of the lung, presumably. Getting that kind of therapy that would only modestly reduce immune function, and I would expect that such an individual would get a reasonably good neutralizing antibody response to vaccine.
Okay.
Whether it be SARS-CoV-2 vaccine or influenza vaccine or pertussis vaccine or tetanus vaccine, it may not be completely completely what you'd expect under healthy normal controls, but it will be quite effective in protecting against severe disease.
Okay. Question about whether you can take the flu and COVID shot at the same time.
Yes, you can. Quite safe. May hurt a little bit, but it's quite safe to do so.
Okay.
Many people choose to stagger them by a week or so. That's fine too, but it can be given same day, same sitting, opposite shoulders.
Okay, great. And last question, someone had COVID 2 months ago, and how long should they wait to receive a booster shot? They had a booster shot back in April.
Yep, good question. And in fact, what I'd recommend here is just remember, and if you can see the slide that's on the screen now, and up at the top right-hand corner, I've got a comment. It says half-life T1/2 or T1/2 of the neutralizing antibody about 108 days. And that's just empirical observational information saying that the amount of neutralizing antibody, half of it is gone in about 108 days. So that's somewhere between 3 and 4 months, isn't it? So if we follow that logic out, we would typically say after your last booster and you're considering another booster, or last dose of the primary series and you're considering a booster, we'd wait at least 3 to 4 months. And public health often recommends for healthy individuals up 6 months to get that booster. And the reason for it is that there's still a lot of neutralizing antibody around at 3 to 4 months. For our patients in CancerCare, I have been recommending 3 to 4 months from the last booster to get the next one, if you like.
So would that be the same for infection?
Now that's where I wanted to speak a little bit more specifically, because having had infection and having had vaccination in the past actually enhances the antibody response considerably, and so that the half-life might actually be longer. And such an individual, it would not be dangerous to leave it to past 4 months. However, I have been on average recommending, just for simplicity, still consider 3 to 4 months. So if it's 2 months from the last infection that was experienced, wait another month, and then so it's 3 months at least, and then go for the next dose of bivalent or whatever is available at the time.
Thank you so much, Dr. Bowe. This has been fascinating, and the research you presented is it's amazing, and it's always ongoing. There's so much to learn, and thank you for explaining so much of this to us, because it's very detailed information, but it's been very helpful. So thank you again, and thank you to our audience for joining us. We really value your feedback, so please take a few minutes to complete our evaluation. And we look forward to seeing you in January for our next webinar. So until then, have a Merry Christmas and Happy Holidays to everyone. Thank you, Dr. Bowe.
Thank you so much. Bye-bye.
Good night.